Hi, this is Brian Kim. I'm going to share with you case number 266 in the best way to do cataract surgery series. And the title of this series is not to suggest this is the best way, but to get you to think critically of your technique so that you can refine and hone your technique so that you can provide the very best for your patient. So this is a dense cataract, marginal pupil, and I'm going to put iris hooks in with my technique, doing 5 points of retraction, one of them which is a subincisional scleral iris hook placement just underneath my main incision. Also, I'm going to put Trypan blue in. But what's interesting in this case, again, you know that I feel strongly about dense cataracts and loose zonules. Well, you can see that the Trypan blue bleeds into the vitreous space and blocks the red reflex. But this is no problem by utilizing mechanical fracturing techniques and concepts. So I'm using a cotton tip to steady the eye, and this is a corneal marker which will help me to center incisor-rhexis. And this is my paracentesis incision, first on the right side and then the left side, making sure I'm parallel to iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. In addition to that, I'm going to make my incisions for my iris hooks. That's my subincisional scleral incision. I go straight through the conjunctiva and sclera, making sure I'm nice and parallel to iris plane. And I want to make sure that I'm low enough away from my main incision so it doesn't intersect my clear corneal cataract incision. This is intracameral epinephrine. And this is the iris hooks. I like to place the hooks in before the viscoelastic, because remember, viscoelastic will cause the iris to be bowed posteriorly, and then access to the pupil will be more difficult. And so you see my technique, very efficient, easy placement of the iris hooks. I just slide it into the incision, push it down, pull the stopper back, and then I roll the hook down, retract the pupillary edge with the hook, and then cinch down the stopper. And I basically do this throughout the entire case. One-handed techniques, two-handed techniques, it doesn't really matter as long as you hold the forceps like I am here, holding it fairly perpendicular to the hook. You have really great control. You can get that stopper back, and then, very subtly just turn that hook tip down, and then hooking the pupil, catching it like a fish hook, and then cinching down the stopper. Again, fairly easy and quick, and you have exquisite control using iris hooks as opposed to dilating rings. So in this situation, I tried to put some air in, but the air didn't go in, and so I'm deciding to just proceed and putting the Trypan blue in. Interestingly enough, I did not feel like it pushed a lot of pressure. I didn't increase the intracameral pressure doing this. And then I went ahead and put an air bubble in because it was just really hard to see. Pushing some more Trypan blue. But again, the eye is rather soft, and so I didn't feel like I was causing a tremendous amount of pressure into the intracameral space to cause that dye to go posteriorly, but obviously it does, and you'll see that soon enough. Evacuating the dye in the bubble with the dispersive viscoelastic. And this is a triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea, and when I'm ready to enter, I dimple down and I go in. This is 2.4 millimeter incision. Using the cannula to control the eye, this is my microrhexis sharp tip forceps by Moria. I have no financial interests. You can see how much the lens wobbles as I'm pulling on the rhexis, and immediately you know that this patient has zonulopathy. I puncture, there's a wobbling of the lens. I pull down, grabbing the right side of the tear, going around circumferentially, using the cannula to control the eye as well. Having 2-point fixation just gives you better control, and I prefer to do my rhexis now every time like this. Finishing off the rhexis. Burping some of that viscoelastic out and that capsule remnant out. And this is a Capsulorhexis hydrodissection technique. I place a cannula under the rhexis edge. I do a little wobble, make sure that the cannula is free. Push some BSS in, lifting the lens up, tilting it, decompressing the bag, and then the lens begins to spin. Again, in general, with these dense lenses, this part is really pretty easy because, in my experience, a dense lens tends to be pretty well disassociated from the capsular bag. Look at the beautiful dilation. I have 5 points of retraction in the subincisional iris. I know without a doubt I'm not going to encounter iris to the wound because I have that subincisional scleral iris hook. Lifting the incision with a chopper, going in with the irrigation off to minimize Decimase trauma, removing the surface epinuclear material. Because this is a dense lens with a wobbly capsular bag, I'm going to sculpt. And this is the terminal chop technique. I'm going to do a stop and chop, switching to the dense mode and sculpting the central trough. You want to efficiently cut the lens into the central dense core as much as possible. I'm going to turn the lens and sculpt a little bit more. Again, this is fairly standard technique for stop and chop. I don't mind using a lot of ultrasonic energy here because you know the cornea is fully covered with dispersive viscoelastic at the beginning of this case. So this is a terminal chop technique. I place the chopper around the rexus edge contra-incisionally, positioning the phaco tip deep, fracturing the lens from the terminal side, cracking it from the terminal side, and then propagating that crack all the way through and through on the other side. This is the cross chop maneuver. I place the chopper under the rexus edge contra-incisionally, hooking the peripheral lens, pulling it central toward the phaco tip, and fracturing the lens in half. Doing the same maneuver around that first quadrant, getting the chopper around the lens, pulling it centered toward the phaco tip, and fracturing that first quadrant in half. And then using mechanical fracturing forces to crush the lens pieces, and then emulsifying that first quadrant. Placing the chopper around that second quadrant, hooking it from the periphery, positioning that phaco tip deep, fracturing the lens completely in half with another cross chop maneuver, using some vacuum, positioning the lens on the tip, fracturing the lens with mechanical fracturing forces, and then emulsifying the lens pieces. Turning the second heminucleus in front of me, sliding the chopper under the rexus edge contra-incisionally, making sure I'm under the rexus edge, positioning the phaco tip deep, pulling the chopper towards the phaco tip acting like a chopping block, and it fractures the lens completely. Placing the chopper around the third quadrant, hooking the lens from the periphery, performing the same maneuver, and fracturing the lens with mechanical forces. Again, very efficient, methodical lens disassembly technique, all predicated upon placing that chopper around the lens equator contra-incisionally and hooking the lens, and then placing the phaco tip rather deep around it, flanking the lens completely, and then chopping it with mechanical forces. By leveraging mechanical fracturing forces, you're less dependent upon high vacuum as well as ultrasonic energy to bury and impale the lens piece. In my opinion and experience, this is a much more versatile way and safer way to disassemble the lens, utilizing mechanical fracturing forces to crush the lens between the instruments. These are the last pieces. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the ironing handpiece. Because I utilize mechanical fracturing techniques, I do not depend upon a red reflex. But as you can see now, I have no red reflex. You can see that the vitreous space is stained with that Trypan blue, which is rather shocking. I didn't know that was going to happen. And because my view for Cortex is really limited, I'm switching to polish mode and then switching to Cortex mode, intermittently changing positions. Ironically, the Trypan blue did not affect me for lens disassembly, but I do have a rather limited view on Cortex mode here. I'm trying to be very careful, switching between polish mode and Cortex mode to remove the cortical remnants. But again, it's rather distracting not having that red reflex, and it's that really dark kind of purplish color. You don't get that illumination of all the intraocular structures the same way when you've had a red reflex. And you can see as I move the eye You get that distinct bluish hue. Interestingly, it's more like a purple reflex because the red of the retina and the blue of the dye is creating this purple reflex. Carefully polishing under the rhexis edge using polish mode, and then switching to cortex mode and just toggling between cortex and polish mode in order to very gently and safely remove all the cortex. You can see there's a little bit of subincisional material that's kind of stubborn here. I'm being very careful in ginger, sweeping side to side, trying to tease that stuff out. Switching to cortex mode when I need to achieve higher levels of aspiration and vacuum. So there you go. Grab that piece. Turning off infusion, pushing cohesive viscoelastic to fill the bag. And this is the Sensor lens. I'm going in pushing more cohesive viscoelastic to fill the bag because as I pushed that injector in, a lot of viscoelastic came out. Pushing more viscoelastic to fill the bag, turning the bevel to the left, delivering the leading haptic into the bag, pronating my right hand, allowing the optic to come out planar, delivering the trailing haptic outside of the eye, and using the Maltzman to dial the trailing haptic into the bag. And now that I have the lens completely inside the eye, I take the iris hooks out. So very easy, two-headed technique. Grab the iris hook, pull back the stopper, rotate the hook off the pupil, and pop it out. Very easy, efficient way of retracting the pupil in a very controlled manner using a 5-point retraction technique, one of which is the subincisional iris hook. You can see beautiful iris. You don't see any trauma to the pupillary tissue, and it achieved the job of giving me excellent exposure for the surgery. Go in with irrigation off, activating irrigation, removing the viscoelastic from within the bag, and then I'll remove the viscoelastic from the anterior chamber, and then I'll hydrate my incision. So this again was a dense cataract. Loose zonules, you could tell that because one is a dense cataract, it had a borderline pupil. But then when I did the rhexis, you saw quite a bit of wobbling of the anterior capsule as I was pulling the rhexis, which again is an indication of zonulopathy. I injected Trypan blue, and again, not in any unusual way, but you can see a significant amount of that dye went back into the posterior area. And instead of having a red reflex, I have a purple reflex because the red of the retina and the blue of the dye has now turned my red reflex into a purple reflex. But nonetheless, this did not affect my cataract surgery. Why? Because I leverage mechanical fracturing concepts and techniques by flanking the lens with the instruments, and in particular, being comfortable and confident in placing that chopper around the lens equator, and then flanking the lens with the instruments, positioning the phaco tip deep, fracturing the lens with mechanical forces, and very carefully and methodically disassembling the lens. Sparing amounts of ultrasonic energy are used. Therefore, I have clear post-op day 1 corneas, and this patient did extremely well. So I hope this was helpful to you, and I thank you for your attention.